Thank you, Ms. Noodleman. I think both witnesses have made the point that two-midnight policy, the inpatient, outpatient, the audits, and the appeals all really work together, which is why we're doing this hearing all together. So, starting Mr. Kavanaugh, I'm interested in hearing your thoughts on the barriers to compare inpatient, outpatient services. Obviously, we should be trying to find the best quality care at the right site with the most cost-effective payment. So can you give me an example of reimbursement difference for a service that can be billed both inpatient and outpatient by a teaching hospital in a major city? What would be an example?
Well, Chairman, as you pointed out in your opening statement, the outpatient payment system and the inpatient payment system are fundamentally different, and they start with different coding. So it's often hard to compare payments because we can't put the same claim through the outpatient system and the inpatient system. They are coded differently. But on the inpatient system, we tend to pay a fixed amount, meaning a DRG-based payment. That DRG-based payment will include adjustments for possibly IME, for DISH. It could include a readmissions penalty or a hospital-acquired condition penalty. But it tends to be a fixed payment for the type of patient and the type of service being delivered. On the outpatient side, it's more disaggregated, where we tend to pay per service. I think you heard from the OIG, and I think it's similar to data we have, that the magnitude of the difference in payment is quite substantial. The OIG mentioned that the short-stay inpatient payments tended to be 3 times as costly to Medicare as the outpatient observation stays. That's consistent with data we've seen at CMS. So that gives you a sense. The systems for deriving the payment are different, and the magnitudes are quite different.
How do you address that?
I'm not entirely sure how we address it. One idea that we received from stakeholders, and I know that has some support in Congress, is to create a payment system that splits that difference, a short-stay inpatient payment system. And as I mentioned in my opening statement, we are soliciting comments on how to create such a payment system. I would say there are challenges. Some of the cases that come in as short-stay inpatient payments already have very low lengths of stay. Chest pain DRG, for example, has a 2-day average length of stay. So the question is, how would you create a short-stay payment around a type of case that's already fairly short? Those are the sorts of technical questions that we're asking for public input in the proposed rule this year.
Thank you. Ms. Noodleman, in your analysis, do you think the two-midnight standard will reduce observation stays or increase them, the length of them?
Yeah, again, our analysis is prior to the two-midnight stay, and it is difficult to predict how things will look. What we did find is that hospitals extremely vary, and therefore it's important to look at all of the data because their starting point is very different, and so it may impact hospitals very differently.
Mr. Kavanaugh, you made thanks for your emphasis describing the different cost-sharing implications affecting our Medicare beneficiaries. That often gets lost in this discussion, and the difference between inpatient and outpatient. It's unfortunate the Medicare program has such vastly different cost-sharing rules for our seniors, our Medicare beneficiaries, between the two benefits. So this committee is focused earlier on the advantages of combining Medicare Parts A and B with the out-of-pocket costs to make sure we protect seniors in part, because we're concerned about what seniors pay for cost sharing. So can you give us your thoughts on combining Parts A and B and how that might be helpful in trying to contain those cost-sharing challenges for seniors?
I recognize that one of the goals is to speak to one of the problems that we have here, which is that inpatient versus outpatient generates very different liabilities for the patient. I'd want to hear more about the proposal that the subcommittee is considering, and we have technical staff at CMS who can come provide assistance to you in the drafting of the bill if required, and if that would be beneficial to the
So you've not taken a look at the proposed combining Part A and B in the President's budget or in earlier health care proposals?
We don't have a proposal on that at this time, but like I said, if the committee has a proposal, we'd love to see it and learn more about it.
Okay. final question. Mr. Kavanaugh, even though CMS doesn't have a direct role in the ALJ level Medicare appeals that Ms. Noodleman talked about, CMS must still be part of the solution to solve the backlog. Does HHS have a working group to address Medicare appeals? And if so, has HHS crafted recommendations to solve the backlog issues going forward?
Yes, Mr. Chairman, as you point out, there is an HHS-wide work group to address the backlog. CMS is part of that. I'd be glad. We are in the process of coming up with recommendations. I don't believe they're finalized yet.
What's the timetable on that?
I think we could brief the committee on them fairly shortly.
Great. Thank you, Mr. Kavanaugh and Ms. Noodleman. I now recognize Ranking Member